Hi, so thanks everyone for attending this bite-sized teaching. My name's Jean and I'm going to be speaking to you today about CPAP and a bit about vapotherm as well. And I'm one of the senior clinical fellows. So on the neonatal unit, you probably have seen that we use CPAP quite a lot through the SOFI ventilator. So what I'm going to be talking about today will be what CPAP is, why we use it, how it's set up, what the main clinical indications are and what some of the contraindications might be, some practical tips to help you use CPAP, and hopefully I'll have a bit of time as well to chat to you briefly about vapotherm and what some of the differences, practical and evidence-based differences are between vapotherm and CPAP. So CPAP, you've got a picture of the SOFI ventilator there, but CPAP basically stands for continuous positive airway pressure, and it's usually delivered by a close-fitting mask or nasal prongs, and you usually cycle between a mask and nasal prongs to prevent injury to the area. So basically with CPAP, you're delivering a constant distending pressure. The aim of this is mainly to prevent lung atelectasis or collapse. And the airways are basically held open at end expiration. So the clinical benefits of this are you have an increase in the functional residual capacity of the lungs. You have improved gas exchange, so your CO2 clearance and oxygenation, as well as improved lung compliance. And by improving your gas exchange and improving expansion, there's a reduction in lung injury and inflammation. However, the main caveat is that you need good respiratory drive and spontaneous respiration in order to use CPAP. I've got a picture here of the mask that I was mentioning, as well as the nasal prongs. And the reason why we use CPAP is basically as a non-invasive method of reducing the need for mechanical ventilation. CPAP has also been shown to reduce the severity of chronic lung disease or BPD, and it can also be used to treat apnea prematurity, and it can be a non-invasive ventilatory method to extubate on from a ventilator. So there have been numerous randomized controlled trials and lots of evidence on the use of CPAP, including the COIN and support trials, randomized controlled trials from the Vermont-Oxford network. But I've got two here that I'll just go through briefly. So first you have the COIN trial from Australia, which was published by Colin Morley and his group, which basically looked at CPAP versus intubation and ventilation of preterm infants from 25 to 28 weeks gestation. And the CPAP group basically had, the CPAP group required less oxygen at 28 days. They tended to have a shorter duration of mechanical ventilation. However, they did have higher rates of pneumothorax. And with the support trial, which was from an American group, they looked at babies between 24 and 27 weeks gestation, and CPAP was started after birth, compared to intubation and ventilation plus early surfactant. And they found that the CPAP group basically needed less days on the ventilator. There was less postnatal steroid use, and also follow-up later on showed less respiratory morbidity, and but however a non-significant reduction in death and neurodevelopmental impairment. So I think this talk is quite short, so we don't have time to go through all of the different evidence, but this is just a brief overview. So the main indications are primarily in the preterm infant who's above 25 weeks gestation, who may be suffering from respiratory distress. And the signs of this, which we all know about, are a fast breathing rate, nasal flaring, grunting or recession, an oxygen requirement, which may be creeping up, or some mild or respiratory acidosis on the blood gas. However, this is, the the clinical signs and the blood gas picture would probably be on the milder spectrum. And if you had a significantly unwell infant, you would definitely need to intubate them. So the common conditions which we use CPAP for are respiratory distress syndrome, transient tachypnea of the newborn, meconium aspiration, chronic lung disease. We often use CPAP as a first line following extubation from a ventilator. And it's also used in some of the conditions detailed on this list. The main contraindications that would make CPAP ineffective or dangerous are upper airway abnormalities, including choanal atresia, cleft palate, or an unrepaired TOF, or a congenital diaphragmatic hernia, which hasn't been repaired yet. So we've got a very useful CPAP guideline on CliniB, and it details how to set the CPAP up and how to wean the pressures of CPAP. But generally you would start with settings of between 5 and 8 on the SOFI ventilator. The actual delivered pressures of the CPAP will be lower than the set pressure. And this is mainly to do with the seal around the mask or the prongs, and it can be the amount of pressure delivered can be affected quite significantly by positioning and also leak through the mouth. So the guideline basically says to start CPAP pressures at about 6 or 7 centimeters of water. You would make sure you have a good seal. You would examine the baby to make sure you've got good air entry throughout. And if it's a newborn baby or if it's a primary mode of ventilation that you're using, you would need to do a chest x-ray to exclude other causes of respiratory distress and to assess lung expansion, even if you're not needing very much oxygen. So that's something to bear in mind. So the main benefits of CPAP are that it delivers a reliable pressure consistently, but it is dependent on having snug fitting nasal prongs or a good seal around the mask. The circuit and the equipment needs to be set up properly in order to deliver this constant pressure. And it, like vapotherm, it is a warmed humidified gas. And it can also, the amount of pressure delivered can also be affected by things like secretions. So airway care is essential. And there are a range of prong sizes, which the nurses will measure up to suit the individual baby. And it's a non-invasive, safe, and well-practiced form of non-invasive ventilation, which is very effective and very easy to use. So I mentioned some of the clinical aspects that we need to consider when you start CPAP. Blood gases need to be kept an eye on, as well as clinical indicators of respiratory effort, including your breathing rate, your heart rate, saturations, and your perfusion. Babies who are preterm as well as term babies need a thermoneutral environment, and we need to keep an eye on their temperatures as well. And as you're delivering a constant a constant positive pressure through the mask or the prongs, babies can often swallow quite a fair amount of air. So you definitely need to make sure you've got either a naso or gastric tube in place, which can be used to aspirate any swallowed air. So as mentioned before, the nurses will cycle between using these binasal prongs and the mask, and this is to prevent any trauma to the nasal septum. And it helps the baby to be comfortable. So with any sort of intervention, there are always complications, although these are rare. Because you're needing to keep quite a good seal around the nose to deliver the CPAP, there needs to be really good care of the nostrils and airway. And this is through regular checks that the nursing staff will do. And also when you examine baby, have a look around the nostrils and the septal area to make sure the skin integrity is healthy. Also, you need regular alternating between the prongs and the mask. Pneumothoraces are rare. They're less than There's a less than 5% prevalence, and often they may be due to an underlying conditions rather than the CPAP alone. And if you have a baby on CPAP with a rapidly escalating oxygen requirement, a pneumothorax needs to be on your differential diagnosis. And there are other complications, including decreased cardiac output from overdistension of the lungs, gastric distension, which we mentioned before, and also if you're inadequately ventilating the baby with CPAP, they may suffer from poor gas exchange. So when babies are doing very well on the CPAP, it can often be weaned, but we do recommend that you do this slowly in increments of about 1 centimeter of water every day until you reach about 4 to 6 centimeters of water. And you would determine how to wean clinically by your work of breathing, respiratory rate, oxygen requirement, and also the underlying lung pathology. And it's a decision that should be made with the nurses and usually on the ward round. It's also stopping CPAP is also a clinical decision, and babies need to be breathing regularly on CPAP of low pressures with low oxygen requirements for a good day or so before you would think about stopping the CPAP. You can extubate onto air if babies are stable, or you may switch onto high flow oxygen or low flow oxygen as required, and that's a clinical decision made by the team. If babies are struggling on CPAP, there are a couple of practical things you can do to improve the efficacy of the CPAP. Prone positioning is excellent for babies because their bellies are often quite large, and lying on their front helps them to expand their lungs a bit better. It helps to overcome any sort of abdominal distension. It helps to aerate their lungs, and they're often quite comfortable being prone. Babies are obligate nose breathers, and if you have an open mouth, the air may leak through the mouth and you may not be generating adequate CPAP pressures, so it's often helpful to make sure the mouth is closed. Some babies just always keep their mouths open, and it may be helpful to have a dummy in place, which soothes the baby as well as helps to close the mouth a little bit. As mentioned before, it's usually helpful to clear any nasopharyngeal secretions, and have a listen and examine babies to check their perfusion and to make sure there's adequate air entry. So how do we tell whether or not CPAP's working? So there's some indicators of CPAP failure, and these are worsening blood gases, which would show a respiratory acidosis despite adequate CPAP pressures. And on the ventilator, you can see how much CPAP pressures you're achieving. And if babies are having recurrent apneas, so if they're stopping breathing, then CPAP isn't going to do enough to continue their breathing, so that then you would need to think about escalating respiratory support onto mechanical ventilation. The other things which you often notice when there's imminent failure of CPAP is that the oxygen requirement creeps up. So you might see the oxygen requirement creeping up above 30% in a preterm infant in the first 24 hours of life, which would be an indicator for surfactant therapy as a rescue treatment. So I'm just going to speak a bit about vapotherm as well. So I come from a unit where we use a lot of vapotherm, so I'm quite familiar with vapotherm um, so it's basically humidified high flow nasal cannula oxygen. It's meant to be more physiological because it is heated to body temperature, it's humidified, and this helps to mimic the type of air you would get delivered into the airways, which would reduce your metabolic requirements. So with vapotherm, you get a constant high flow. It's different from CPAP because you don't get a set positive pressure, but it does have an impact on the airway distending pressure by producing positive airway distending pressure. You also, you're washing out any CO2 from the nasopharynx, which helps to eliminate any CO2 retention. And it also helps to reduce inspiratory resistance by providing a positive airway distending pressure. However, like CPAP, it does require a good respiratory drive, and you need to be breathing spontaneously in order for it to work. So the benefits of vapotherm are that it's generally more comfortable. The equipment is less bulky, and it's easier to handle for cares and cuddles because you don't need to maintain an adequate seal at all times. So useful for things like kangaroo care, breastfeeding, and cuddles with parents. Because the nostrils aren't obstructed by the cannulae, and you're only meant to use prongs which are less than half the size of each nostril, there's less nasal trauma with the vapotherm prongs. However, the main disadvantage is that it's quite costly. So each set of tubings, when you start a baby on vapotherm, cost about £100. So it might not be the best option for babies who are unlikely to need non-invasive ventilation for a long period of time. It's probably more useful in a longer term setting. Additionally, with CPAP, you have a measured pressure that you deliver, so you know exactly what you're giving, whereas with vapotherm, the amount of positive airway support that you're providing can be quite variable, so there's no way to monitor that. And also there have been reports of increased air leaks with vapotherm. So you should consider vapotherm in preterm babies with chronic lung disease, especially if you're weaning from CPAP support. So this is if you're using CPAP pressures of less than 6 centimeters of water for about a day or so in lower oxygen requirements, so that you know you're happy on CPAP and you're unlikely to need to escalate your respiratory care. You could also go to vapotherm if you're struggling with nasal trauma from CPAP. And also it might be useful in babies who have been intubated primarily for a surgical procedure and then need to go on to some form of respiratory support postoperatively. The main contraindications are if you've got upper airway abnormalities, especially if you're using any airway adjuncts, if there are any signs of respiratory failure or cardiovascular instability or apnea, and also as the evidence is debatable in the extreme premature infant, especially when you're extubating from the ventilator for the first time, it needs to be used with caution, and practice varies from unit to unit. So the amount of flow that's delivered through the vapotherm is 4 to 8 liters per minute, and lower flows may be sufficient for smaller babies. And in terms of weaning the flow, if you have a larger infant, you would reduce the flow by 1 liter a minute. And this is only if the oxygen requirements are less than 30%. And if you've got a smaller baby of less than 1.5 kilos, then you would reduce the flow rates more slowly, so reducing by 0.5 liter a minute if you've got low oxygen requirements and the baby is stable with good gases. So with CPAP and vapotherm is similar. Good practice is similar for both of these modalities. You need to look at the oxygen requirements, look at the baby clinically from an ABC point of view, looking at how they're breathing, how comfortable they are, looking at the past day or two to see if there have been any changes in the apneas, brady's, or DSATs, and looking at the trend on the blood gases. Babies, especially those who are small, tire very easily or may have poor weight gain. If there are non-invasive supports of these, need to be considered as well. So there has been, I'll just finish up by touching briefly on the evidence behind vapotherm. So there was a recent Cochrane review published a few years ago comparing high flow and CPAP. So high flow as in vapotherm and CPAP. Compared to CPAP, there were about 4 randomized controlled trials which were included, and there were no significant differences in the primary outcomes of death or chronic lung disease. But babies on vapotherm did appear to need a longer duration of respiratory support. Apart from this, there were no significant differences in any other outcomes. And following extubation, going on to vapotherm or CPAP, they looked at 6 studies, which included a total of just under 1,000 babies. And there were no differences in primary outcomes of death or chronic lung disease, and no difference in the rate of treatment failure. But they did find that with vapotherm, you do have reduced nasal trauma, and on the Cochrane review, they found that there was a small reduction in the rate of pneumothorax. However, with all of this evidence, there is less data on the extremely preterm infant and also the mildly preterm infant. There are also different devices which deliver high flow oxygen. So on this unit, we use vapotherm, but there are other types of devices available, and it's difficult to compare evidence, especially if different devices have been used. But vapotherm has been used for a number of years, and it has been found to be similar in efficacy to CPAP in preventing treatment failure, death, and chronic lung disease. Does anyone have any questions?
There's actually one question, if you like, to answer that.
Yeah, okay. So deciding, I'll just read out the question. So deciding which one to choose, I guess, depends on the unit. Vapotherm for long term, I guess. Yes, I think Katerina, I think you're right. I think each unit has its own habits of which one they're more familiar with using. And with CPAP and vapotherm, you really need very good nursing care to choose the right prong size, to make sure that you're doing observation and cares in the appropriate way. So, whilst the evidence for CPAP is better, I think depending on nursing experience and the experience of the unit, I think each unit probably has its own fashion. And Jonathan has a question. Is there any evidence for term babies receiving vapotherm for TTN and RDS if gases are normal and SATs okay? I think, Jonathan, in response to your question, with vapotherm, the actual the sets for the tubing are actually really expensive. So if you have normal gases and the SATs are all right, you'd probably be less likely to use vapotherm for a prolonged period of time. So it's harder to justify spending that amount of money setting up with a vapotherm if it's only going to be for a period of a few hours. So in that case, I would, and at St. Thomas's NICU, I think CPAP would be the preferred modality. Anna, correct me if I'm wrong.
Yeah, right. At the moment, we do prefer CPAP. I mean, in a couple of situations, according to the recent trials, at least CPAP is superior to high flow nasal cannula oxygen in babies less than 26 weeks when you extubate them, because reduce the risk of failure post-extubation.
Yeah.
And then, as you said, when we envision that the patient will need non-invasive respiratory support for a short period of time, we would prefer CPAP over high flow nasal cannula oxygen, as Jonathan was suggesting, for example, TTN and RDS in a near-term infant, because, I mean, there's a cost that's definitely different between CPAP and high flow in those patients. So if you open a high flow circuit just for a day, it's a much higher cost compared to using the CPAP circuit, and you don't really get much benefit.
I think with the Sophie ventilator, one of the really fantastic practical things are that if you extubate a baby onto CPAP, you still have the option of going on to SNP-V as well with the same circuit, with the same ventilator. So it's nice to have that backup option as well if CPAP isn't working.
Yeah, and there's somebody else. If it was really cheap, though, it would be an option. So, Jonathan, if you look at all the trials and studies being done to compare CPAP and high flow, we have not shown any superiority of high flow over CPAP, and the majority of the studies have been done to prove that essentially high flow is not inferior to CPAP. So, what I can tell you is that high flow is not inferior. I can't tell you that it's better. So I wouldn't, it would be an option, but using high flow instead of CPAP, but it wouldn't be like it's better to use high flow.
So there have been no improvements so when you compare primary outcomes of death or chronic lung disease, you don't see any benefit of vapotherm over CPAP.
Yeah. And then, yes, you were mentioning the use of SNP-V as an option, which is great. I appreciate that some other units don't have that option. And to be honest, other units might not use a lot of high flow, or in the past we didn't really use a lot of high flow, and we still were finding strategies to ensure the better support for our patients. So I think it's really useful to see what we use here, but as you presented at the beginning, it's useful to understand the basic understanding of CPAP high flow, and then apply that in different contexts, whichever hospital you're working in, because every hospital might have a different type of device and a different type of policy in ensuring that we look after our babies at our best. So there's a highlight, there's another question. I don't know if you see that?
Yeah. So yes, Haley, I can see your question. So in our unit, we tend to use vapotherm for babies going from mechanical ventilation to CPAP and then to vapotherm when we know they need a while on the vapotherm. So if you've got, for example, on the unit at the moment, we've got an IUGR 29-weeker who's 700 grams. They were intubated, had 2 doses of surfactant, extubated very quickly onto CPAP, and they were doing fantastically on the CPAP with no oxygen requirements. So we swapped them over to vapotherm, and currently the corrected age is 30 weeks gestation. But the rationale behind using vapotherm in that baby was more comfort in terms of less nasal trauma. It would support their growth and help to reduce the work of breathing required, to humidify any inspired gases, as well as reduce the work of breathing. And also being on the Vapotherm might help the baby to have more cuddles and kangaroo care. And also because it was a 30-week small baby, we knew they'd be on the Vapotherm for quite a while. So we thought that the cost of using Vapotherm would be justified. And also because we'd observed the baby on non-invasive ventilation, which was the CPAP, for about 4 days or so with good gases and no oxygen requirement, we were confident that baby wouldn't need to be reintubated and we wouldn't need to re-escalate non-invasive ventilation. So then we swapped over to Vapotherm. And this would also help baby in sort of stepping down to HDU care, especially as they're establishing feeds.
Good, well done. Looks like we answered all the questions.
Okay, thanks Anna. Thanks guys.
Bye.
Bye.